So we mean by, or we define esophageal rupture by tear in the esophageal wall that lead to leakage of gastrointestinal content to the mediastinum, causing irritation, inflammation, which followed by infection that cause a rapid deterioration that led to sepsis and death if not treated. It's rare, but if it's happened, it's devastating and it's a life-threatening condition. Risk factors, mainly iatrogenic, for example, patient post-procedure like EGD or upper endoscopy, or if they ingest foreign bodies for pediatric age of patient, or if they ingest toxic material that causing irritation to the esophageal wall that predispose the esophageal wall to rupture. Usually, patients will present with pleuritic retrosternal pain. Usually, patient you present with a chest X-ray with the finding of pneumomediastinum or subcutaneous emphysema. Usually, you will see mediastinal air either on the chest X-ray or CT finding. Can someone tell me about the chest X-ray? What you see? What are the findings in the chest X-ray in a patient who presented with esophageal rupture? ممتاز. Where? Excellent. It's around the heart border. We call it a pneumopericardium. Okay. If you have this sign in a patient that you suspect that he has esophageal tear, this give you a clue. What about this X-ray? Again, you see around the heart border, there is a mediastinal air. So we call it pneumopericardium or pneumomediastinum. What about this X-ray?
Subcutaneous emphysema.
ممتاز. Subcutaneous emphysema, bilateral. You can see it in the chest wall, beneath the chest or the lung, but on both sides, as well as you can see around the neck, there is air, which is abnormal finding. So we call it subcutaneous emphysema. How we treat the esophageal rupture? Usually, it's rare to do a surgical repair. Usually, treatment is supportive, like going with ABC first, then administering the antibiotics, and keep the patient MBO. And in severe cases, you might like place a stent that to cover the tear, and sometimes you might do a failed all the line of therapy. You might do a surgical consultation to repair the tear, but typically it should be like a medical management. Unless if the patient continue to worse with no improvement, then you might consider a surgical repair. This is algorithm how to approach patient with life-threatening causes of chest pain. So the most important is to do ABC. Then based on the causes or based on the condition or underlying cause, you will decide or you gotta specify the treatment according to the cause of chest pain. For example, tension pneumothorax, you should do a needle decompression or tube thoracostomy. For pulmonary embolism, based on the severity, if it's massive PE, you should do CBA if there is no contraindication. For aortic dissection, based on the type A, it's a surgical emergency and the patient should be referred to cardiothoracic surgery. For type B, usually the treatment is medical by controlling the heart rate and blood pressure. This is our talk about the first lecture, which is the life-threatening causes of chest pain. Any question?